Unstable Vitals is the podcast that takes the pulse of American healthcare, and the prognosis is critical. Dr. Adam Brown and Dr. Lara Zibners, physicians turned entrepreneurs and business leaders, expose why the system is unraveling before our eyes.
And welcome back to yet another episode, Season 2, Unstable Vitals, because healthcare is unstable and
so is she.
So are we. This is a joint project. Hi, Adam. How are you?
I'm doing well. How about you? I'm a bit tired, to be honest. I've done a lot of travel, but I mean, that's comparing it to you, which is not a lot of travel.
Please cry me a river.
Right. Well, that's why I can't really be like, oh, I was out in San Francisco and then I was in North Carolina and then I'm going back to London and I can't. And you're just like, yeah, I've already done that trip like 14 times over in the same amount of time. So,
and I walked it.
Right, exactly. So in high heels. So, you know,
Totally.
you're like the
My
Fred
back is
Astaire,
killing
Ginger
me.
Rogers. You can do everything he can do except backwards and in high heels. So this
That's
is why
right.
there's no competition here.
That's right. Anyway, it's nice to see you. I'm in California today, on my way back to London tonight. So there you go. I woke up this
Yep.
morning and said, I can't do this anymore. I'm so tired of being tired.
Yes, I get it. So, but you know, this is not about you, Laura. This is
It
about
is
Rob.
always about me. Actually, I'm about to make it all about me.
Okay, go ahead.
So, guess who we have on the show today?
I know.
I know you know. Does everyone else know?
No, but I'm
Okay,
excited
this
about
guest
this
has been
one.
waiting a very long time because he was very jealous that one similar person was on this show already and he hadn't had his turn yet. This is somebody who is not only an extraordinarily accomplished healthcare professional, but
He has to put up with you.
he is a freak in the sheets. And I
Stop.
mean the Excel spreadsheets. I would like you to meet the man with the eye for detail, the most obsessive compulsive detail orientated person I've ever met. But thank God, because I fly way up here in the sky. It is my hot husband, Robert Pinate. Yay, Robbie Bobby.
Welcome, Robbie Bobby.
Hi,
We're
hi.
so excited to have you on.
I'm
And
listening to
bless
that
you,
voice.
child.
Say something, darling.
Have you already, I'm going to say something. Have you already petitioned the Pope for like a sainthood to have to deal with Laura? My
I
husband
bel
tried, you know.
yeah, I believe my beatification is in the post, so I'm just waiting for it. So yeah, it should be through soon.
Good. Welcome.
Thank you so much. Thank you for finally. No, I'm joking. You guys have covered so much in terms of the breadth and the depth of healthcare, and as you said, the unstable vitals is a perfect name, isn't it? Particularly with the way the world is going at the moment. And I've just always wanted to shed a bit of light on what is it like the other side of the pond, and having being a nurse and still a nurse after 31 years of working in and around emergency medicine. I hope I can shed some light, bring
Well,
Yeah.
some insights.
and I wanna start there because just listen to that voice. I mean, right? Yum. But I did marry a nurse, and I
Yep.
think we should start asking Rob why he went to nursing school, and it's not because he wanted to give back to humanity. Tell him the real reason, love.
Well, I wasn't a
How
great.
many women were in your class, and how many men?
Well, we'll get to that. Um, the the reason why I fell into nursing, it's true. I wasn't a great student actually when I was 16, 17, 18 because I was having far too much fun playing sports and chasing girls. Um, and I just was not a good A grade student. I certainly wasn't anything like Lara at the same age. So so in the UK we do A levels, and I did my A levels and I did it all in humanities and I did terribly. And then it was a bit of a wake up call. So I was 18, unable to go to university. I didn't have the grades, and it was a bit of a wake up call. And I was like, what on earth am I going to do now? And my next door neighbor was a nurse, and she said, "You'd make a great nurse." And I was just like, "What?" And then I looked in more into it with my parents and and it was like, oh, actually, and I also at the same time, and not because of nursing, at the same time I flipped. I shouldn't have done humanities. I love them, but I'm terrible at them in terms of exams and whatever. I flipped and I did math, chemistry, I did English literature again, and I did what's something called general study. And I did, and in 1 year. So it's as opposed to 2 years, 1 year. And I did okay. Um, and it wasn't until I went to university and I did a degree in nursing, which back in 1992 was a rare thing. Now it's standard. That's when I flourished. So that's when suddenly the switch, someone hit the switch, and yeah, 3 years later I qualified as a nurse, and I always wanted to do emergency care because there's a program in the UK that's been running since the 80s called Casualty, and it's like ER but nowhere near as good.
Mm-hmm.
And there's a guy in Casualty called Ash, and he's the charge nurse, the senior nurse within the emergency department, and I just always wanted to be him, and that's how I fell into it. And we weren't allowed to set foot in the emergency department until year 3, and finally I did my placement 6 to 8 weeks, and then I was really worried that I'd hate it, and luckily I loved it.
And the rest is history.
Yeah.
I think it's a couple points here. I think, I don't know fully about Laura's story. I know that her dad's a doctor, and mom was a nurse, correct? Your mom was a nurse too.
Yep.
So I think for me, it was very similar to you, Rob, my kind of like getting into emergency medicine. It was a combination of someone saying, oh, did you know that you could be a doctor and you would be good at it? And I was like, oh, okay, cool. And it was ER on television. And it was kind of like that mix of watching those two things. But I wanted to dig into something, because one of the reasons why we wanted to have you on was not just because you're Robbie Bobby and not just because of Laura. Let's kind of like move Laura out for a second. But no, one of the things is that we talk about is how the United States healthcare system is unstable, but we're also hearing that there's instability in the UK healthcare system and other systems around the world. And I know that as I talk with students and people from around the world, that there's no healthcare system that has it perfectly. And so one of the things that we wanted to have you on for was to give your perspective, because you're not just a nurse. You're a nurse, you're a nurse executive, you understand kind of like the broader system, you understand the problems that are having in the broad kind of NHS, the national health system within the United Kingdom. And there's some overlaps and there's some similarities with what we're dealing with. So the UK or the European system is not perfect, has its issues. So tell us more about, and this is why we wanted to have you on, is to kind of bring some credence that healthcare is a universal problem. The operational issues are a universal problem with different features and facts and things around it. So tell us more, like, we know how you got into nursing, but you focus very heavily in the operational side of looking at departments. And so give us kind of some just broad overview of the UK healthcare system and then what you do within it.
Okay. So let me start with me, just so people can understand what I do. So I'm a something called a consultant nurse, and we can get into that later. But just think of a very high level advanced practitioner, and I can describe more about it, and Lara can tell you exactly what it means, what it looks like stateside. But I'm a consultant nurse. That's what it's called. So I came up through an advanced practice route, but I was also an educator. I've always been an educator, and now that's the title that I hold. And I've been a consultant nurse for since 2012 with 2 different hospitals. I work at University College London Hospital, and in 2020 I began working, in addition to the day job, as it were. Some of my time is spent working for NHS England, which is the governing body of the NHS. And specifically, my role is I am something called a clinical associate. And that is because I have expertise in my field, emergency nursing and emergency care. And my job is to go around the country and support organizations to improve their emergency departments. So I've had the pleasure and the privilege of going through multiple hospital emergency departments, and I literally will walk it through with you. I will try and do a diagnostic with you, not just me on my own, I hasten to add. This is a big group, but we all work for the NHS. So we don't charge the hospital for this service. This is the whole point of the NHS, right? This is free. And that's my job. So my expertise in particular around the nursing processes, particularly the front door, triage and streaming, as we call it. But I'm also an expert in rapid assessment and treatment systems. I've studied them to a very high level, but I also help organizations to develop them and implement them. So I cross over with medicine. And that's the key thing to remember about my role is I cross over with my medical colleagues. But also I'm an expert in advanced clinical practice, and I helped to write the curriculum, the national curriculum, as part of the Royal College of Emergency Medicine ACP credentialing program, amongst lots of other things that I've done, but people can look at my LinkedIn and see what I've done historically.
So can I just parrot that back to make sure? So it's similar in the United States when you go to an emergency department, or what you call in the UK, the A&E, but when you go to the emergency department, you have a condition, cough, cold, gunshot wound, whatever, you're seen by a nurse at the front end, determines by triage, your level of severity, and then kind of puts you into one area of the department or sort you into levels of priority. So who's being seen first, who's being seen second, and where they may be seen. So what the role you're doing in the UK, shock, similar type of system, there's of how people come in the door, but you're looking at how do we make this more efficient operationally? How do we actually ensure that there's smooth workflows, the right number of resources, the right number of nurses to address the patients? Is that kind of what you do? Am I describing it right?
So no, you are. So I still go into a lot of departments and walk through with the leads, and they describe what they do now. This is the key thing. Don't go in and tell them to change something you don't understand yourself. So you go in and you do the diagnostic, you do the talking, you do the watching, you do the now because of what I am, I can literally stand next to a nurse, I can stand next to a doctor, and I know exactly what it is they're doing, and I'm trying to figure out why they're thinking that, why they're doing that. And it's normally historical, as in it's so ingrained that it's about getting people to think differently. That's my job. My job is to get people to think differently. So most departments that I go into, the system hasn't changed for 30 years. So when I qualified in 1995, we had a patient comes in, they book in, register, they then wait, they then triage, then they wait, then they get seen by the most junior doctor you can find in your department, then they wait because we're waiting for all of these tests that we requested, and then they wait again, and then finally a senior person comes in and says, okay, well, actually you need this is what we should do, right? So this linear process takes hours. So what I do is I help people to come in and actually break that down. Why are you doing a system that has been operating for decades? Why aren't you thinking differently? And that's where streaming and that's where rapid assessment and treatment comes in. And the very shortest form I can give you is rapid assessment and treatment fundamentally flips the model on its head. Why do we have our senior doctor at the end of the pathway? Why don't we just move them to the beginning and start making the right decisions right from the beginning? And that's the same with streaming, with nurses. Make the right decision. Next person, the most senior person I can find. So that's encapsulates really the process. But not all hospitals will implement that. Not all hospitals will implement it in the same way. And my job is to translate that and bring it to a site that works for them. There you go.
No, it's fascinating. It's interesting. Laura.
And this is what I was going to say. He's a freak in the sheets, and I mean Excel, because he is like the most detailed. You know what's interesting? So back to how you get into emergency medicine, I actually was going to do pediatric cardiology and matched in a cardiology fellowship, and then did 2 months in the ED back to back. And all the attendings were like, "You're not one of them. You're one of us." And I think that was well spotted, because most of us in emergency medicine have ADHD. And I didn't just make that up. Like, that is a statistic that's where the doctors with ADHD go. But Rob has the opposite issue. He's so detail orientated that he can see things and take the time and pay attention and just observe, whereas I could not do his job. I would fly, like ER docs, we fly in and we're like batting our arms around and then we fly back out. Whereas the nurses are the ones who actually are sitting at the front door and having the patient come in. And I think, as well, I can tell you he's in high demand because he's one of the few nurses in that group. But he does have to travel to really weird places with names like Chester. Okay.
Mm-hmm.
Can you guys hear my pinging? It's my family. I put myself on focus. I've said do not disturb. I have said stop texting me. I don't know what to do. Rob is out here in California with me right now, and yesterday was the first day I let him see my sister's home. How'd that work?
Well, here's the thing. Okay, so let's do some education for Laura. There is, for those that don't know, this is called an iPhone. An iPhone has different types of things on it, and one of the things here on the side is a silencer.
I
Look,
have that
boop,
on.
boop. It's
It's
boop, boop.
silent. It
You
is
have
silent.
to make the noise.
It's silent, and then my computer also has, if you work in a Mac, your messages come on, and even if you try to shut messages off, they're ping, ping, ping. And I've got this family that, yeah.
See, Rob, again, this is another proof point of why we
So
should go
this
back
is
to
a
the
great
Pope.
segue for a moment, because we will come back to what Robbie Bobby does. But for 1 minute, I met Rob. For those who don't know, I also practiced in the UK. And so I actually met Rob at work at the Royal College of Surgeons in London. And so I had my own version of going into the UK and being like, why do you do that? Even though the room looks the same and the medicine is kind of the same, Rob's had the flip experience marrying into an American family of doctors. And yeah, I think he's made some interesting observations there.
Yeah. Well, I want to ask you, talking about the differences between, the UK and the US, let's frame that out a little bit. I mean, we talked about like specifically what's happening in the ER, but like, tell us more about the numbers, kind of England by the numbers. How many people are we talking about? What does the NHS do?
Yeah. That's a great question, because I think it's about just framing it for people that don't know or understand the NHS, right, in England. So I'm going to talk about some numbers which are England, and I just want to make the distinction that England is not the UK. So, right, so I'm talking about the country of England. Why? Because NHS England is just England. So it's not Wales, it's not Scotland, and it's not Northern Ireland, okay? That would be the United Kingdom. So, England.
But what's Great Britain?
Great Britain is Scotland, Wales, and England, not Northern Ireland. Right? So it gets So I'm just going to talk about England, okay, just to frame that. Okay, population. Let's talk big numbers here. Population, 58.6 million, okay? That's 84% of the UK population. Just to give some context to that, California is 39 million, all right? So the entirety of England is 58.6 million. The land mass is 51,000 square miles. That's roughly the same size as Alabama. That's it. Right?
And you were just in Alabama, so you know.
I know. The whole of the US, so including Alaska and Hawaii, 3.5 million square miles. England, 51,000. So it just gives you a sense of scale, but also you get the sense of how many people we pack into that space, right? 58.6 million. All right, NHS, let's talk about money. In 2024-25, so our fiscal year works from April to March, all right? So not like the American system, which is January to December. So that's why we always talk about 24-25 or 25-26 years. 204 billion spent on the NHS, and that represents 40% of government spend, which is by far the largest department. The Department of Health and Social Care is by far the largest government department. It represents about 10.9% of GDP. Interestingly, the US, in figures that I could find, is about, you guys spend actually 16.7% of GDP on healthcare.
And that's actually can be low, because there's some reports that are closer up to 20. It just depends on the year, but yes, you're right. It's kind of nuts, right?
When you just gives you a sense, right? We're kind of in the middle of the table of countries, similar countries. Workforce, we have 1.5 million people, full-time equivalent, so not heads, not head count, full-time equivalent working in the NHS. So it's by far the biggest employer of anything. And actually, if you look at global stats of employers, it's up there. It's up there with Amazon. It's up there with these enormous international companies. Let's talk about my profession just for a minute. Nurses, midwives, and nursing associates have to be registered with the Nursing Midwifery Council. And in the UK, because they don't break down the numbers, in the UK, all right? 860,000 people registered to practice, of which nurses, so not midwives, not nursing associates, just nurses, 793,000. Now, not all of them work in the NHS. We do have a private sector,
Hmm.
but it's not, it's small.
I
It's
think,
small.
can we stop there for one sec? Because I think that that's something I did not understand as an American. You'd hear the NHS and socialized medicine. You don't realize that the NHS is the safety net. It is the base where people get their care and where they know they'll get care. You don't have to get your care in the NHS. You can step out into the private sector. And so it's not just that you have no choice, right? But for emergency medicine, what I always tell people is in the UK, you can't private your way out of a major trauma because all emergency care happens within the NHS.
Yeah, I think that the key here is there a private sector? Yes, predominantly for elective stuff. The only thing I would say is the vast majority of people in the UK, in England, cannot afford to go private. So it's a misnomer to think that they can do that. They can just choose to do that. The vast majority of the population simply cannot afford to do that. And also the NHS is there to provide that service first and foremost. But how do we fund it? Well, because we're through our taxation. Okay, so let's be clear. It's not that it suddenly just comes for free. We pay for that service, but that means that when I go and attend and require the service of the NHS, it is free at the point of delivery.
I want to go back to something about, I think that's important framing. When we talk about the NHS, some people are thinking about it's just the insurance system, and it's not. So, the UK is different from Canada, for example. Canada has a public baseline insurance system and then has a mix of public hospitals and private hospitals. In the UK, the vast majority, there are some private hospitals like HCA, Cleveland Clinic, Mayo, but the vast majority are all NHS hospitals. The insurance program is NHS. The doctors, the nurses, the technicians work for NHS. So what's different from, say, Canada is the doctors and nurses don't necessarily work for the Canadian government. They may work for the private hospital, but everyone has an insurance card. So it'd be like here in the United States, everyone getting Kaiser Permanente insurance, working in a Kaiser hospital, all the Kaiser doctors and nurses and you're all working for Kaiser, or you're in the VA system and you only work within the VA system. So that's a really important thing to understand. So it is a closed, for the most part, system. And to your point, Rob, I think, as you mentioned, as I've talked with a lot of people in the UK, I mean, you're a citizen, my husband is, most people do NHS only. They don't go out and get private. Some people that are a little more well off say, I'm going to buy a private insurance, BUPA, and I'm going to go then to private hospitals or pay out of pocket. But that's a fairly small percentage.
Yeah, in the grand scheme of things, I don't know what the percentage is, but it's pretty small. And a lot of people will have that benefit through their work.
Mm-hmm.
So their job will come with private medical insurance.
But it's supplemental. It's a
Yeah,
supplemental thing.
it's an add-on.
NHS,
Yeah.
right.
The key thing about the NHS system, bearing in mind it was created in 1948. So the whole idea behind it is we pay towards it through taxation. If you're below a certain threshold, if you earn below a certain threshold, you don't pay a penny. But that doesn't mean you don't get access to it. You get exactly the same care and exactly the same services offered to you as someone that pays and earns 200,000 a year. The person that only earns 12,000 a year below the tax threshold, they may pay a little bit of national insurance, but essentially below the income tax threshold, they will get the same care. There's no differentiation. So it's not about what you earn. It's about you being in the system and requiring healthcare. So it's about trying to get the best for everybody. And I talk about it, and you guys will know this in emergency medicine. What I love about what I do, what I've always loved about what we do, is I don't care who you are. I don't care whether you're a high flyer or someone that, I don't know, that has the lowest job you can think of. That's just as important to me as a human being and they will receive exactly the same treatment. They can have the same tests, they can have the same medication, they can have the same referral, they can have the same outcome. That's what I love about it. It's the ultimate leveler, ultimate leveler. Okay, so we never ask, do you have insurance in the UK? Not in the emergency department, because it's irrelevant. We never ask what you can afford. It's irrelevant. And the bit that blows a lot of Americans' minds is when I prescribe, because again, my role means I can prescribe drugs. I can prescribe any drug that you would normally do in emergency. I can request a test. I can refer you. All of that. Yes, I record it, but it's not. I don't think about the money. I don't think, oh, that's going to cost this much. I don't think about charting it and, oh, that I must. No, it's just, I just do it because it's the right thing to do for the patient.
So do you think it's a little compare and contrast? Do you think that it's better? Is it good having one central ethos of how we're taking care of patients, one body of doctors, nurses, hospitals, all working together? Is that a good thing?
I think it can be for the greater good. I think that doesn't mean there's not disparities within the NHS, right? So we know that some hospitals do far better than others. We know that hospitals generally in deprived areas will struggle more because they'll have a higher demand on them. The patient population, sadly, will be more unhealthy. They'll have more comorbidities, etc., etc. Less access to the right healthcare earlier on. You know, let me give you an example. A GP practice in a very deprived area, the numbers of patients on their books per GP, per doctor, will be far higher than in an affluent area, right? So we know that it's not perfect. We haven't cracked the disparities of healthcare due to socioeconomic factors. Okay, it's not perfect, but the fundamentals allow us to ensure that everybody gets care. And actually, for most people, I would say that if you're really sick, you will still get great care, irrespective of where you are.
I think that was one of the things that I found the most freeing when I started working I was an honorary consultant at St. Mary's for a number of years. In the US, I had to know every insurance. Like I would have to check a patient's chart, what insurance they had, and that affected my discharge decision making. It affected what I sent them home with, who they follow up with, who I call. When you're in the UK, you don't do that. You just do what you think is right. As a result, because the system you can't be perfect and you can't do everything. But so we actually would have a lot of patients return to the ER on a scheduled appointment basis, which you would never do in the US, because they would go to their primary care doctor. It's a different system.
Except for rabies vaccines. That's it.
This is rabies vaccines. That's right. Except for that. But we don't test for rabies in the United States anymore. So never mind. Yeah, but no, it was super freeing because I can remember as a fellow, I had to know everybody's insurance, and back in the day, who covered a nebulizer and who covered an MDI inhaler, right? You had to know, oh, that insurance won't cover this and that won't do that. You don't do that in the UK. You just take care of the patients.
Well, yeah, and let me give you a real life example. So we introduced a digital healthcare record system into our hospital. UCLH. It's called Epic, which a lot of you will recognize because it's come from America.
Have you ever heard of Epic, Adam?
Yeah, I may have just written an op-ed about it, but maybe.
That's what I thought. So we introduced it into a hospital. This is a few years ago now, and it's completely transformed the way we work. I think it's a great system for lots and lots of reasons. But what was fascinating was we had the American team come over and help us build it for our purposes, and there was these rooms of consultants and people like me and lead nurses, and we were developing it from a clinical standpoint. And it was hilarious because the Americans kept on talking about billing. And we were like, stop talking about billing. It's not a thing. What you mean is we need to record that we've done a catheter. You need to record that we've done some blood tests. You need to record, but stop talking about billing. And people actually started getting really annoyed with them. So they realized they had to stop talking about billing. It's not a thing we don't talk about it. Do we record it? Yes. Do we have a tariff that sits in the background? So if you come into the emergency department, the average cost to the NHS, this is going to blow people's minds, right? If you come to an A&E department, somewhere between £173 for your visit up to an upper threshold of somewhere around £563.
So $200 to $700, somewhere around
Correct.
there. Yeah.
That's it. And that higher number is because we've actually done a lot. We've put in a chest drain, we've done a CT scan, we've done this, that, and the other. So those are the sorts of numbers, and that's economies of scale. So back to your point, Adam. Does it help? Of course it does. We're not talking about a system which is a hospital-based system. We're not even talking about a regional-based system, statewide. We're talking about a federalized system for the entire population of the country. That's economies of scale, because not everybody needs healthcare, but they're paying their taxes. So you use that money for those that do need healthcare, right?
It's an insurance pool in some respects, you know.
Yeah, it is. And but because you've got that greater good ethos within the whole makeup of the NHS, it allows those economies of scale. That's the beauty of it.
I want to go to something you said about Epic. You know, in one of my roles, I work in revenue cycle and coding and billing, and we all know that the EHR interface with the clinicians and the work can sink revenue significantly. There can be lots of revenue leakage. And one of the primary reasons that EHRs in the United States have been created the way they have been is for the purpose of billing. Yes, they were supposed to be a part of the High Tech Act, that where everyone had to be in this type of electronic platform, because the whole idea was if we're moving towards value-based care, we have to be able to extract data, we have to know utilization rates, we have to know approximate costs and charges and things so that we can back into what's working, what's not working, where are there inefficiencies, where they're not. That was kind of like the idea behind the act. But the real thing is that Epics and Cerners and Meditech, and in your case you mentioned Epic, they were built to optimize billing. The excess charting is to optimize billing. And so it is fascinating when you say, hey, I actually like Epic. I would love to see a side-by-side comparison between what is the data input that I would have to put in the emergency department in the US and the nurses, and then what's the chart output versus what happens in Epic UK. I have a strong feeling that the data, the clinical data may be ultimately similar, but the amounts of data that we're having to put in for the purpose of billing is likely dissimilar.
When I was working in New York, I remember we had to hit so many review of systems to get to a certain billing level. And so, you know how this works. To maximize your efficiency, you create these like standard templates, right? I had my chair exam, my across the room exam, like the kid's ripping the room apart, he can probably go home exam. And I had to excessively do review of systems on each of them just to make sure that they could get the maximum, because if turned out it was something big and we could get max billing for it, if I had only listed musculoskeletal and hadn't said, you know, his sense of smell was top notch, right? Whatever, you wouldn't get that, but it's overcharting, right? It is meant to extract data, but you overchart. It's irrelevant what somebody with a broken toe really, like how their nose is working.
Well, the good news is some of that has changed to where most, at least within the emergency department, the actual billing is based upon the complexity of the patient, the medical decision making. But that really hasn't trickled down into much change in how much that we're documenting now. But Rob, you know, so that's a good thing. But the charts look very similar. There's not a lot of change, and the doctors are still putting in a ton of information, and nurses are doing the same. I wanted to switch gears a bit just because of time. We've talked about a lot of the positives. So big population, almost 60 million within England, a standardized system. Yes, there's disparities, but you can go anywhere and get treated as a part of the NHS. They're not worried about insurance, you know, and your GDP for healthcare is quite a bit lower. And fun fact, people in England live longer than they do in the United States. So, you know, value-wise, you're getting a better bang for your buck or for your pound, you know, for lack of better terms. But there's some negatives. You highlighted disparities, but what are you seeing now that you're kind of seeing both sides of the pond in a way? What are some of the negatives that you're seeing to the NHS system?
I think it's the last, I'd say since about 2010, Not surprisingly, there was a change of government in 2010. And this
Austerity,
was
austerity, austerity.
us, right. So, as with any healthcare system, I think globally, it's a political football, right? And there's always been an argument about how do you distance the politicians from healthcare, and I don't think anyone's cracked it. Certainly, we haven't. Because it means in our system we have a general election approximately every 5 years. The parties can change in that sort of time frame. Well, guess what? That they expect the entire NHS to pivot and just to start doing something differently rather than just saying, actually, no, you're doing really well, just keep going. Anyway, back to the austerity thing. That was a political decision. It was a choice. We didn't have to do austerity. Other countries didn't do austerity post 2008 crash. That's a whole different discussion. But that's the choice that was made. And we have been chronically underfunded as a healthcare system and social care system in particular, bearing in mind they are two slightly different parts of the same puzzle. And we are now paying the price. There is no question that we are paying the price. All of the standards that we were achieving back then, we are failing to achieve now. So the 4-hour standard, which is a standard within emergency care. So you should come into an emergency department and leave the emergency department within 4 hours. Not be seen within 4 hours, finish within 4 hours. We actually still manage, so 2024-25, we manage 73.9% of all patients, 27 million in a year, coming to the emergency room would leave within 4 hours. Okay, just to give you the sense. But that's bad. We used to do 90-odd%. So we're not hitting that target. We're not hitting something called the 18-week wait target. We're not hitting cancer targets. And the list goes on and on and on and on and on. So the NHS is in a far worse position now than it was 15, 16, 17 years ago because of political choices which are inevitably made. Well, not inevitable, but political choices that were made. Now we've got a change of government, right? So Labour's got back in. Labour created the NHS, and now they are trying to turn the super tanker. But like any super tanker, well, that's a bit politically. I didn't realise I was talking about super tankers, given what's going on in the
The
Middle East.
NHS is going through the Strait of Hormuz, I guess.
Yeah, basically. So it takes at least, I think it'll take 10 years to turn this ship around. But Labour may not stay in power for 10 years. So then what happens? So is the NHS in a worse position now than it was 10, 15 years ago? Without question. I think what I found personally very difficult, and a lot of my colleagues that have been around as long as I have will also attest to this. We had this extraordinary period in the 2000s, the first decade of the 2000s, seeing the NHS get better and better and better. We got more efficient. We were delivered better care. We had better outcomes. And just seeing that slowly wither on the vine. I call it a death by 1,000 cuts. It's never one big thing. It's just the cumulative effect of cutting here, cutting there, freezing here, jobs freezes there, just continual. And it's brought us to this position. And now we're trying to turn the ship around. But a lot of people have suffered as a result. Healthcare outcomes have deteriorated in some respects. So that's the challenge when you've got such a big system.
It's a warning. It's also a lesson, and also not surprising, all rolled into one, right? You know that healthcare costs are expanding, are increasing because utilization is changing. Our technologies are getting more refined and better, and our treatment options, but that also costs something. And so when that's happening, plus you have inflation, granted, you know, over the decade post, after the systems were juiced quite a bit after the financial crisis, you have all of those things kind of pouring together. You can certainly see that it's a perfect storm, that if you cut the legs out from someone, they're not going to be able to run. And it is unfortunate. I think we're seeing some similar things happening decade over decade with like declines in Medicare rates for doctors, cuts to Medicaid, which is underinsuring or not insuring large portions of the population. And that has a trickle down effect, creating more disparities in some of our most vulnerable areas. It's kind of a story that we keep seeing and we do nothing about it.
That's one of the similarities I've seen in the two systems is that the actual frontline providers, and that's often the emergency department, but certainly the doctors and nurses, they if you make it so hard for them to do the job that they showed up to do, you lose morale and you lose workforce. And I think that that's the part that's really not understood by what I call the Gucci's, the administrators who walk around in nice clothes and make decisions without really understanding the implication of the front line. And I think we can see that that's happened. I mean, I'm certainly hearing it from my friends. I left the U.S. 20 years ago, but it hasn't gotten better. It's gotten a lot worse. Everyone I talk to. And I hear the same thing at home from Rob, about and I think you've said it, that you haven't seen the morale and conditions like this in a very long time.
No. So when I visit certain hospitals, bearing in mind my job and the job of the rest of the people that work in the group within the NHS England, so it's called getting it right first time.
Gerfed.
So it's called getting it right first time, and
Not grift,
so
girfed.
yeah. So there's a whole group of people, and I never work alone. I've got my colleagues in GERFT. They're experts in their field around all sorts of processes and data and this and that and the other. What I bring to the party is my clinical expertise. So being an emergency nurse of over 30 years. What is so challenging sometimes is going into a hospital and we're asked to go to the most challenged organizations in the country, walking through the emergency department and seeing doctors, nurses, porters, healthcare assistants, receptionists, all the people that make your emergency department work. So many an emergency department doesn't work without those porters, without those receptionists. I think they're just as important as we are, right? And you walk through them and you think, this is what it was like in the 90s when I qualified, when the NHS was on its knees. And we've gone full circle, right? We've gone absolutely full circle. And to see that level, those sorts of conditions that the people are working in, again, 20 years later, yeah, it's difficult sometimes because you're just like, it doesn't have to be like this. I know it doesn't have to be like this because it wasn't like this. And now we're back to square. It feels like we're back to square one in many respects.
So we have 60 seconds left. I just, one of the things that we like to ask is that, healthcare is unstable, but what do you think, Rob, that we can help stabilize the healthcare system and make it better? What's kind of your high level takeaway?
Ooh. Well, all right. So two answers. The first one is far too easy for me to say, which is more funding, right? As we've already pointed out, everyone bangs the drum in the UK about it needs to be more efficient. Well, actually, if you look at the numbers, we're pretty darned efficient. We are one of the most efficient healthcare systems in the world. So, for instance, 10.9% of GDP, right? So we must be doing something right. I guess the key thing for me is, and it reflects what I do, is often when I go in, you actually do have the tools and you do have the people and you do have the thought to make things better. What no one ever gets in frontline is time to think, time to step back and look at what they're doing and saying, how can we do this better? And I'm so lucky that my job is to literally go in and pull the right people away from the front line. I literally put them in a room sometimes with a blank piece of paper and say, forget everything you've been doing for the last 20 years, which is a difficult conversation to have. How can we make this better with what we've got? This is the reality, but we can still make it better. And we've seen some real successes, and we continue to see real successes around the country. And that I think is the green shoots, as I say.
Well, and I will let Adam bring it home, but I just want to add that we didn't even get to touch half the stuff that you've done in your career, and I'm super, super proud of everything he's done. We didn't talk about, he actually wrote the credentialing for emergency nurses, advanced practitioners in the UK. He's one of the only nurse consultants not credentialed because he wrote the credentialing. So he's the chicken or the egg, depending on the day. He founded the major nursing trauma group. Like, he's done some really extraordinary things. But right now he's, super happy and passionate and won't quit no matter how much I try to get him to live full time with us. So we will continue to allow the NHS to have him for a while longer until I can drag him away fully. But I'm really happy that we got to have Robbie Bobby on, because I'm very proud of this man.
Oh, you should be. I'm so glad that to have you on as well, because it's the perspective is interesting, and when we're trying to solve healthcare problems, oftentimes to make things more stable, we tend to look inward and we just kind of still like bear our heads down and we just keep going through the day. But sometimes you have to look externally, like what's working in other places. Just Rob, as you were saying, put people that are on the front line in the room, give them a blank sheet of paper and work on a solution. Having people with different perspectives, backgrounds to say, can we do this better? I think is a really, really important way to help solve the problem. So I am very grateful for you. Thank you, as someone who lives in the US and the UK. Thank you for making the NHS better, because I probably will have to go there at some point in time too. So, but thank you so much for joining us. We really appreciate it.
Thank you so much. Thanks, guys.
All right. Bye. Have a wonderful one. Take care.
Thanks for tuning into Unstable Vitals. If you enjoyed this episode, make sure to follow us for more unfiltered conversations on the pulse of healthcare. Connect with us on LinkedIn or visit us on unstablevitals.com to stay in the loop.